Welcome to the HL7 Da Vinci Community Roundtable. Today's session, use case progress and patient matching success, how to improve interoperability and patient safety. My name is Alex Goss, and it is my pleasure to moderate and present in today's Community Roundtable and to remind all of us that we engage in these forums under HL7 antitrust policies to ensure appropriate collaboration and information sharing. We so appreciate your participation in today's Community Roundtable, Da Vinci's educational webinar. We have two segments in today's webinar reflecting a slight pivot in our Community Roundtable approach for 2023 to bring more implementation experiences to the stage. In usual fashion, we'll offer key news, events, and priority updates. We've expanded our project updates this month with a refreshed view of our 2023 priorities and this year's finalized use case roadmap. We'll conclude the project update with use case spotlights on 3 use cases: price cost transparency, clinical data exchange, and member attribution. This will also set the stage for this month's user success story from Opala and MultiCare Connected Care. They will discuss their patient matching journey using the Da Vinci Member Attribution Implementation Guide to improve interoperability and patient safety. I'll be joined by Jocelyn Keegan, HL7 Da Vinci Program Manager and Payer Practice Lead at Point of Care Partners, Kallem, HL7 Da Vinci Project Manager and Senior Consultant with Point of Care Partners, Vanessa Candelora, HL7 Da Vinci Patient Cost Transparency Co-Lead and Senior Consultant with Point of Care Partners, and Meghan Quint, Vice President of Solutions and Customer Success at Opala, and Anna Taylor, AVP of Population Health and Value-Based Care at MultiCare Connected Care. We've included time to take audience questions, so please use the question function in today's GoToWebinars panel. We have muted all of our lines so that we can aid the quality of our recording. So please make sure you use the question box to ask your questions. We will definitely take them at the end, and time permitting, we might take them midway through. If you are having audio issues, please consider using the dialing in with the session number provided in your registration link, or leaving and coming back in can also resolve some audio issues. There will be a survey at the end of the webinar, so please help us by completing it. We do take that feedback seriously and review it, and it helps us to evolve our programming. This session will be recorded, and its slides will be posted as well on our Da Vinci calendar tomorrow. Our next Community Roundtable event is April 26th, 2023. And we'll post our details on the Da Vinci calendar in our usual fashion. We have, in 2023, a new membership model, and we're expanding our membership with this new revised fee structure, and we would like it if you would please consider joining us in creating and implementing standards that enable efficient value-based care information exchanges. In particular, we're focused on missing stakeholders from small and community-based providers, regional and Medicaid, CHIP, and qualified health plans, and missing integration partners from EHRs, population health, and other platforms. So please consider this opportunity and reach out to us at davincipmo@pocp.com. I know we all may be a little bit NPRM'd out these days. We have been very, very busy in our extensively engaging our members to prepare responses to the 2 proposed rules that we refer to in shorthand as Interop 3 and Attachments Proposed Rules, or NPRMs. Our submissions have been posted on our main Confluence page under Project Resources, Industry Statements, and Updates. We are tracking, as is the rest of the industry, with the additional Federal Register releases that addressed missing content on the electronic signature standard and the extended comment period. We are not currently planning to amend our submission. However, we will be in touch with our membership to confirm next steps. In regards to upcoming events, next week brings the Vibe event in Nashville, and the following month, HIMSS 23 in Chicago. Vinci will be present at both of these events, and we invite you to stop by and visit us. We've noted our locations on the slide. In early May, HL7 will hold a Connect-a-thon, its fire testing event in New Orleans. The testing event is held over the weekend and flows into the May working group meeting. Plus, both of these events will be held at the same location, the Hilton New Orleans, Riverside. For those of you who may be new to the idea of working group meetings, or WGMs, they are to provide HL7 international work groups a chance to meet face-to-face to work on standards, as well as the opportunity to network with industry leaders from around the world. It also provides an invaluable educational resource for the healthcare IT community. In addition to our typical work group meeting approach of advancing HL7 standards for use across the globe, this work group meeting will include presentations and breakouts on the role of policy in the advancement of healthcare interoperability standards development and adoption. This is a terrific opportunity to bring your policy and business colleagues to an HL7 working group meeting so they can better understand the interplay of policy and standards development within the US and internationally. The event starts out with setting context on day one, such as understanding what fire is, why it matters, and why the industry groups are coalescing as accelerators to solve their business challenges. The second day is US realm focused with an extensive federal participation and presentations and updates from accelerators such as Argonaut, FAST, Gravity, and the Cairn Alliance. The day 3 themes span fire's use across the globe by highlighting international initiatives, as well as the Center for Disease Control's use of fire in public health, along with updates from the Helios Accelerator and sessions related to the International Patient Summary, Digital Identity Management, and Social Drivers of Health. The 4th day brings additional federal agency and accelerator updates, including Vulcan and Codex accelerators, along with sessions to showcase the use of fire to achieve various regulatory and policy objectives. Additionally, over the 4 days, there will be breakouts to take deep dives into implementation guides and discuss the United States Core Data for Interoperability, USCDI, version 4 design. I encourage you to check out the robust agenda because I've just given you a thumbnail sketch, and the agenda is on the HL7 website. And this will help you determine whether you'd like to attend. And you should also note that there are tutorials available to gain an even deeper knowledge base in fire. Early bird registration is available through Friday, April 7th. It is now my pleasure to invite Jocelyn Keegan to come on screen as our first presenter in our use case roadmap and priorities update, which will lead us into our use case spotlights. Take it away, Jocelyn.
Awesome, thanks, Alex. You can go ahead and flip to the next slide. I'm super excited to be here, and I want to double down on one of the points that Alex made as she was kicking off, which is, we're constantly evolving this format in this forum, and we're so grateful for how many of the community members come, prep, pull together materials, and get up on stage and talk to us about their journeys. But we did recognize that we were maybe short shrifting some of the progress of the program and details about the use cases and where they are and how to get involved in them. So this format that we're using this month is a new experiment. And as always, we're open for feedback. We'd love to hear what you want to see more of and less of, because we know that everybody's super busy and we want to make sure that we're good stewards with your time. So with that, I want to talk a little bit about where we have gotten to in establishing our 2023 priorities. And it's always a good sort of touchstone for us to be able to get through the planning process of Q4 and into Q1. And, as Alex mentioned, the gifts of some MPRMs to make things interesting, to really finalize and formalize what it is that we're going to focus on from a program perspective every year. And again, the level of work we've been able to accomplish and sort of the realness of the work and how we're measuring progress of the work in the industry is palpable at this point in time. So you'll appreciate my little tagline we've been saying over and over again, right? We've put the foundations in place. We've seen these APIs, fire APIs, be a requirement for more and more parts of the industry. And so that foundation is out there. And it is remarkable to see the implementation pace and progress that's happening in the industry. And while a lot of folks aren't talking publicly about what we're doing, if you attend a few DaVinci calls or some HL7 connect-a-thons, or work with your partners, you'll get to, I think, a clearer view on what's happening sort of behind the scenes, or maybe a little bit quieter in the industry. But I expect in 2023, especially as we head into sort of conference season, you're going to see DaVinci and references to FHIR APIs in standards more and more, I think, in the conversations that we're going to see in the presentations that are going to be out there. So there are APIs live in production. It's like I said, it's remarkable to see the progress. I'm excited to have Anna Taylor come back and talk about how she's starting to onboard additional payers and new and better features, based on these reusable APIs that we have invested in the industry. So we will do what we do, which is continue to build implementation guides, test them, mature them across the industry. We're really excited to, I think, have gotten CDex, I think, to where it really needs to be from an industry tool perspective. I heard today it was officially published. I don't want to steal any of Crystal's thunder, but it's been a long road there, and I think that the capabilities in that base guide are really remarkable at this point in time. And so we, along with really strong support from the membership, I had shared some indications about 2/3 of the members said that they were planning to, were working on, or had already developed against CDex as part of our member survey this year. We have heard the industry, and we are now setting up time and bandwidth on a weekly basis to start to really build out the example set, the samples of how one would use CDex with different roles and actors for different business problems. So if you're not paying attention to those calls, we're still in the early norming, forming, how are we going to actually do this example thing in FHIR sort of conversations, but please come join the calls and bring your SMEs that really are the people that are really trying to figure out how to get to that clinical data level in the industry. And then we are excited that we've actually kicked off a new use case that our team, Athena team, actually had proposed about 1.5 years ago and has been slowly organizing in the background about leveraging FHIR for some gaps in the existing X12 world. And this was for multiple people to get access to their remittance advice. And so we've kicked off an internal discovery project and are hoping to be able to bring that live sometime in the first half of the year as a public use case. But in the meantime, just so you've got it on your radar, if you've got folks that are dealing with some of the challenges around remittance advice for multiple payees, definitely watch the listserv and get involved once those calls go public. And then the second big investment our third big investment that we're doubling down on is really the next phase of patient cost transparency, which Vanessa will go into more depth on today. But again, excited to see how we are creating standards where there really is nothing in the industry to do this work today. So look forward to her update. And as always, especially with the NPRM, we're going to finish publishing across the board all 3 guides, and then starting to double down on what was in the rule that might require some advancement or some expansion of the existing guides, and then just continuing to incorporate feedback from market on the burden reduction guides. Then lastly, you heard Alex reference it, but I will say, I'm more than happy, and I know many of the existing members or other PMO members are happy to talk to you about what does it really mean to be a member of DaVinci, either as a sponsored member, as a provider, or a contributing member actually helping to fund the project. It's a really positive experience, and more than happy to talk to folks about what that looks like and what it might how to best onboard your organization to the program. I've included links here to 2 things. The first is the actual membership slides that Alex referenced are on the main page of the website, and then we have a new page which most of you have seen in a PDF format, which is DaVinci in Action, which is really the community starting to show more publicly where they are in their progress of a particular guide. And I think this is really important when we think about how do you find people to know who's actively working on the use cases you're working on. So take a look at that page. We'll be working to flesh that out over the next couple weeks in the run up to HIMSS. But we've pushed it out to public because we actually want the entire community to share where they are and what IGs they're implementing to really help, I think, with that matchmaking. That was a big piece of feedback we got from members in surveying. How do I find other people that are working on the stuff that I'm working on? So this, short of there being live endpoints available, sort of in a production environment, this is a way to start some of that crosswalk who's working on what and, what stage are they in their development. And then to the right-hand side, I won't go in these in detail, but, we'll continue to do evangelizing, advocacy, and the partnering work that we've done in the industry and respond to, opportunities like MPRMs throughout this year. Because we have found holistically, I think that's been one of our sort of secret sauces, is making sure that we're really holistically dealing with building the community, not just focused on sort of writing implementation guides, in a siloed environment. So I think this holistic approach is really, showing that there's a way to grow this community ahead of any regulatory requirement on these implementation guides. Alex, can you flip to the next slide? I'm going to make a couple points today. Crystal's going to do a walkthrough of what the actual more Gantt chart view of the guides look like for this year, but just want to remind folks that maybe haven't been spending as much time with the project is, we're using an organizing construct here of, we think these are the communities of users, but, we understand these guides can, sort of slip and slide into different categories depending on how you're implementing them. So it's really an organizing construct. So don't put too much weight on sort of how things are organized from a box perspective. We continue to evolve the format and sort of the notations that are on here. So changes probably since we've last looked at these slides is, we've revved all of the dials and the arrows, and I want to make sure people understand what they're looking at. So the color coding is really based on 3 factors. The first is, where is it in the regulatory process? Has it been mentioned? Has it been referenced? Higher or lower, because that drives adoption, regardless of the maturity of the guide. Where is it maturity-wise in the HL7 process? Is it an STU1? Is it an STU2? We've now had DEQM advancing, to STU4, starting to look at industry support of some of these guides. And then the last factor is, how much is it being used? So because something could be less mature, not in reg, but have a lot of people picking it up and using it. And I'd use member attribution up into this last at NPRM as an example of that. It's a really good utility tool, right? That people are picking up is something that they need to improve how they share information compared to the fragile ways that we do that today with business partners. And then the last point that I would make here, as far as changes to the highlighting, we've sort of updated, where is something being referenced in an actual regulation, where is it being referenced or expected to be referenced in a coming regulation or an MPRM. And then one guide, I made a denotation here, the plus sign denotes that PCDE was mentioned in the MPRM that was just out. We actually have put that guide on hold and had after the last Interop 2 rule was issued. And just want to make a note to the audience that it does exist, it's paused, and we've actually moved the bulk of the functionality in the rule into CDex. And so we think CDex can serve that content, and we're going to pause further investment and continue to pause further investment into PCDE until I think the industry itself has gone through this first wave of API adoptions. And with that, I'm going to let Crystal talk to you about sort of what the actual progress is like at the use case level and start to introduce her, and Vanessa will talk to you guys through some of the actual use cases.
Great. Thanks, Jocelyn. Next slide, please. So I'm going to spend a few minutes today just to dig a little bit deeper into the overall plans and timelines for our Da Vinci IGs this year, in addition to the corresponding events that support the testing and advancement of these guides throughout the year. It's hard to believe that we're nearing the end of the first quarter of 2023 already. We've accomplished a lot this first quarter and have so much more planned for the remainder of the year. First off, STU4 of the DEQM, or Data Exchange for Quality Measures Implementation Guide, was recently balloted this past January. DEQM provides a framework to enable automatic data collection and submission in support of value-based care data exchange. And this is one of our most mature implementation guides, and the community is really driving progress and adoption here. So for those of you who are interested in continuing or engaging in those efforts, the community meets every other Thursday at 2 p.m. Eastern if you'd like to dive in as part of their work efforts. In addition, STU2 of the Member Attribution List Implementation Guide was also balloted in January. And as Jocelyn mentioned, we're going to be providing a deeper dive into the Member Attribution, CDex, and patient cost transparency use cases later in this presentation. So I won't spend a lot of time on those guides at this point in time. In February, Jocelyn also mentioned that we launched the postable remittance use case. That is in discovery phase, and we will talk more about that particular use case in the coming months. But we are really excited to see the broad participation and support for this effort, with nearly 30 DaVinci members already attending these discovery calls. The Payer Data Exchange, or PDEX implementation guide, is nearing publication of STU2, and there is a lot of interest and momentum here, especially as a result of the recent proposed regulations. PDEX enables health plans to share key clinical data and patient history with patients and other payers. After STU2 is published, the community will continue to support testing and assess the need for additional STU enhancements in support of future regulatory requirements. That PDEX community meets regularly, weekly on Fridays at 1 p.m. Eastern time, and there's a lot of activity going on there. PDEX also has 2 companion implementation guides. So you'll see reference to the PDEX formulary, which is a published STU. It was published as STU2 in August of 2022. And the PDEX Directory Plan Net, which was published in April of 2022. Both of these particular PDEX guides are companions to the core PDEX implementation guide, and they may also receive some STU updates later this year pending implementer feedback and assessment of regulatory impacts as well. STU1 of the Risk Adjustment Implementation Guide was published last year in June, and we're actively working on STU2. It's slated for ballot this coming May. The Risk Adjustment Implementation Guide provides the ability to better inform providers of opportunities to address chronic conditions, enables payers to communicate risk adjustment information, and enhances the government sponsor's ability to allocate funding more accurately. It also reduces administrative burden for providers by standardizing the reports they receive from all payers. Although we considered balloting this guide earlier this year in January, we decided to wait to allow for additional testing in January and again in May, and we're planning to bring this STU2 back to ballot in May. So if you're interested in learning more about this particular standard, review and comment on the guide as part of the May ballot cycle, participate in testing, and engage in the ballot reconciliation process this summer. That group meets every week on Thursdays at 3 p.m. Eastern. The burden reduction use case has 3 implementation guides that work together: Coverage Requirements Discovery, or CRD, Documentation Templates and Rules, DTR, and the Prior Authorization Support, or PAS-IG. We are finishing up ballot reconciliation across all 3 of these burden reduction guides and hope to have them published around the June timeframe. Then the team will pivot to bring any draft content back to ballot as soon as it's reasonable, including any industry feedback from early adopters and impacts from expected regulation. Value-based performance reporting, or VBPR, is a brand new use case which was launched in the fall of 2022, and that implementation guide is slated for ballot this coming September. It's focused on standardization of payer-generated cost performance reports, which are crucial for health systems and providers to track and manage performance on value-based contracts. The VBPR team is planning to hold its first round of reference implementation testing in May, and we are so excited about this capstone IG because it enables partners to share critical contract progress in real time, thus filling a major void. So please encourage your colleagues to engage in these efforts by attending weekly conference calls on Mondays at 2 p.m. Eastern and through testing at the upcoming Connectathon this year. The Notifications Implementation Guide is a foundational asset that defines a framework for real-time exchange and alerts. This particular IG was published in October of 2020, and it has been in wait mode until the subscription model is matured in FHIR R5. Several of our members have leveraged this utility IG across early adoption FHIR projects, and we have received some feedback from these early adopters and plan to do an STU update in the coming months. The team is holding quarterly conference calls to support implementer questions until R5 is released. The next call will be on June 7th at noon Eastern. Lastly, throughout the year, we work with the community to provide education and support opportunities to conduct testing, provide feedback, and drive innovation. The bottom portion of this roadmap depicts key industry events where DaVinci has a presence. So we're currently preparing to showcase DaVinci's hard work and success during the upcoming VIVE conference next week, the HIMSS conference in April, and the HL7 Connectathon and working group meeting in May. Next slide, please. I will now hand it over to Vanessa, who will do a deeper dive into the patient cost transparency use case.
Thank you so much, Crystal, and thank you, Alex and the Da Vinci team for inviting me here today. It is great to talk about patient cost transparency. This use case is very exciting, not that everything that Crystal just mentioned, wow, is Da Vinci doing a lot of amazing work in the industry. But to dive into patient cost transparency for a little bit here, this slide should look pretty familiar to all of you that have been participating on previous community roundtables in the past. And so it's very similar to some of the other snapshots or pieces of information that we have across Da Vinci use cases. You can learn more about what the patient cost transparency use case is all about, which is really to provide a standard for data exchange in support of payers and providers to share cost information to patients in advance of services. And so this use case started a few years ago before the No Surprises Act, as part of the Consolidated Appropriations Act, was really taking hold in understanding in the industry, as it continues to do so today. And there has been an exciting couple years of regulation in this space that has helped to drive our broader view of trying to solve the bigger industry problem of patient cost transparency in the United States. And so we've included some recent updates here on this slide. I'm crossing my fingers for publication any minute now, hearing that the CDex Clinical Data Exchange Guide was published today. I checked immediately when I heard Jocelyn say that earlier, but we are still awaiting any minute now the publication of our standard for trial use 1 for patient cost transparency. The implementation guide is available. It is linked on this slide. The continuous integration build is what is soon to be our STU unpublished version as soon as we are up in the queue for publication. So please check that out. We made a lot of really significant updates in those next 4 bullets under recent updates that I reviewed on a previous community roundtable, but there is a lot of great stuff that we learned from the community after balloting this guide last January, and made a lot of those updates throughout last year, getting to where we are. Looking ahead, I'm going to talk a little bit more about some of these, but we have really entered our phase 2 at this point. So we are looking for those of you that are interested in joining us to test at Connectathons, to test against our reference implementation, to look at our guide and implement it, particularly if you are driving towards what we covered in phase 1, which I'll discuss in a minute, and also to contribute and join us. We meet on Fridays at 11 a.m., more information in coming slides, and we'd love for you to get involved, get your teams involved in improving patient cost transparency data exchange. Next slide, please. So this is a summary of what we did in phase 1, that guide that I mentioned that should be published any minute now. Essentially, at a high level, this is we created the ability using FHIR to communicate good faith estimates for services or items from providers to payers, as well as providing an advanced explanation of benefit from a payer to a patient, and optionally back to that same provider that submitted the information. So this is in support of the No Surprises Act, particularly the piece for insured patients that are expected to receive an advanced explanation of benefit. And we recognize that the regulation for that is to come in support of that law that went through Congress. Next slide, please. And so this is another view of that same workflow. Essentially, we created a FHIR GFE submit post request that goes from a submitting provider or facility to the payer upon the patient's scheduling of services or request. And then the payer would compose that advanced explanation of benefit, and there is the ability for a GET request from a patient or third-party application, as well as from the submitting provider. And that is something that we heard from the community. That's why it's a dotted line down there, because we strongly heard that that was really important for providers to be able to be a part of that conversation with cost with their patients and have equity of information as questions may arise, and having that whole care team involved. But it's not necessarily part of the law, and again, regulation to come. And so I want to call out just a couple things that I have done in the past for those of you that may be new to this work. There is a expected, supported by X12 FHIR to X12 mapping for the good faith estimate that we know is being worked on. And this implementation guide is meant to facilitate data sharing that is new, right? So there is no HIPAA mandated transaction for patient cost transparency. There are other transactions that HIPAA mandates that are related to claims, for example, and they may be able to support patient cost transparency, advanced estimates for services, but that is not a HIPAA mandated transaction. So in some ways, we are really leading the work in this industry on how estimates can be done in advance of services with knowable information, which is challenging and fun. Next slide, please. So many of you may have seen back in the fall, there was a request for information put out by the tri-agencies, Department of Labor, Treasury, and Health and Human Services. And it sought information to have recommendations on this advanced explanation of benefit and how to transfer the data from providers and facilities to plans, as well as economic impacts for some of these requirements. And the Da Vinci response is linked here. We convened Da Vinci members to compose a response to support that request for information. And it really called out the need and the need for technology and the opportunity and potential for using FHIR and APIs and modern technology to support this process for payers and providers today. So aligned really well with the work that the Patient Cost Transparency Group has been doing. And thank you again if you participated in that. Next slide, please. So phase 2, we kicked off our phase 2 scope in early February. So it's been a couple months now, and we are building upon the work that we did in phase 1 with actually an upstream, if you think about the workflow, an upstream effort to gather the information for good faith estimates when multiple providers are involved. So we very quickly realized that the way that estimates are provided today, if they are, it doesn't pull together cross-provider or cross-billing provider estimate information. And so leveraging FHIR APIs for this new workflow is something that the group saw an opportunity to help the industry with. And so our objectives for phase 2 are to add the ability for a convening provider to notify co-providers and request information for a good faith estimate for expected services when multiple providers are involved. We also introduced the concept of a coordination platform that can help support that convening provider at the discretion of the convening provider to help communicate and handle some of that data needed exchange. This supports current and future regulation as well, aligns with some of the requirements in the No Surprises Act and current regulations for the uninsured or self-pay population, as well as the insured population of patients. Next slide, please. So just to give people a visual, if you're a visual person, that phase 2 box that's in the middle, it is not this simple as a back and forth between convening providers and co-providers. There is a lot of terminology work that we're doing. I'm probably using terms you may be less familiar with, convening and co-provider. However, just to give you a sense of where we are in the workflow of a real world scenario, it would be sort of upstream between providers to help gather that information. Next slide, please. So that's where we are today. Again, we encourage you to join us on Fridays. We meet at 11 a.m. Eastern time for 1 hour. And we hope that you will bring your subject matter expertise. We're currently digging into requirements around what information is needed at the time of scheduling to inform the co-providers on what they would need to be able to accurately, to the best of their ability, estimate costs and planned services. And so if you have subject matter experts, office managers, schedulers, health IT professionals, revenue cycle professionals, or those that are deep into the cost transparency world that is ever changing, we strongly encourage you to join us. And you know how we gather this information, and then how can the technology and APIs support it, as it is very new for our industry to be thinking about this, and we recognize that business processes will need to change in addition to the technology to support them. So hope you can join us, and please feel free to reach out to me if you have any questions or the team. Thank you. I will turn it back to Crystal for the next slide, I believe.
Great, thanks, Vanessa. So we will now dig a bit deeper into the CDex implementation guide. CDex is a utility tool that can be used across all the Da Vinci use cases to support the exchange of clinical data generated by providers to be shared with payers and other providers. And I was so excited to share the late breaking news with you today, but we've talked about it a couple of times, that STU2 of the CDex implementation guide, which was balloted in September of 2022, was just published today. We're so excited that it's out there now and ready for folks to pick up and use. So most recently, we added a variety of updates to the guide, including requesting and sending attachments for both unsolicited and solicited submissions. We added a FHIR-based approach to requesting attachments from a provider for claims and prior authorization. And STU2 also includes the ability to request attachments using questionnaire functionality, which it also aligns with the burden reduction DTR functionality. So some of the DTR or the questionnaire functionality is still in draft format, and we've put that out there for the community to begin testing and evaluating. In addition to getting these the most recent version of the implementation guide published, the Da Vinci community also reviewed and responded to CMS's proposed regulation for healthcare attachments transactions, which Alex mentioned earlier. So this newest version of CDex is compliant with the HIPAA and Affordable Care Act requirements and the attachment standard that can provide support for claims, referrals, and prior authorizations. Looking ahead, we really need some committed participants to come and test at Connectathons. This is one of the best methods to gain experience with the standard and support the community with further improving and enhancing the guide. And so if you're willing to test and are planning to participate in the Connectathon, we're really looking for that input from folks. We'd love to know in advance of the Connectathon, help you prepare, do some coordination in advance. And in addition, we're looking to the community to help contribute and expand the CDex example set for community use, which I'll cover in a bit more detail in a moment. Next slide, please. So this is another visual depiction of how CDex works for attachments for claims and prior authorization. Currently, claims and prior authorization requests come through X12 transactions or portal submissions, but payers may need additional information from a provider to determine if the services being billed or requested are supported by medical or policy benefits. So this slide illustrates the exchange of clinical data or attachments between a payer system and a provider system for claims and prior authorization processes. And these attachments can be divided into solicited or unsolicited workflows. For an unsolicited attachment, the provider will submit additional documentation based on a payer's predefined rules without any request. And for a solicited attachment, the provider will submit additional documentation in response to a payer's request. Next slide, please. CDex has matured a lot over the last few years, and it can now be used for a variety of clinical exchange scenarios. So in addition to supporting claims and prior authorizations, CDex can be used to exchange clinical data between referring providers. It supports digital signatures with clinical data exchange, and it can support the gathering of additional information for quality programs and risk adjustment between payers and providers. The format of the data exchange is not limited to FHIR resources, but can include CCDA documents, PDFs, text files, and other types of data. I should also note that the HREX implementation guide is a foundational guide for all of our Da Vinci guides. It defines FHIR profiles, operations, and guidance that are relevant to all Da Vinci use cases. So implementers who are using CDex should also be aware and understand the HREX implementation guide. Lastly, in 2022, we conducted a member survey where we asked some specific questions about building additional scenarios to support the multitude of ways that CDex can be leveraged to enhance clinical data exchange and improve care. Through this survey, we learned that we have compelling interest to expand the investment in CDex by supporting the community with development of more detailed scenarios. Next slide, please. The CDex implementation guide provides several generic examples to illustrate the different approaches for exchange of clinical data. However, CDex is primarily a framework IG and does not detail the specific payloads and specialty-specific data requirements in all instances. Implementers need examples that exemplify the variety of scenarios and data sets that can be supported by CDex. So as a result, earlier this month, we launched a scenario building process for CDex, and we hope to leverage our community of payers, providers, and technical experts, and those experts involved in health information and utilization management. Our goal is to take a holistic view. We are working to identify categories of information that may serve as inputs to examples. We want to then drill down and identify common sets of data that are being requested. And we also plan to leverage existing artifacts, such as profiles and templates that have been already defined for commonly used artifacts like CCDA. Ultimately, we hope to lower the threshold of entry by helping the community build and contribute examples that can be reused and progressed by others, and advance adoption and further improve the implementation guide. So we strongly encourage you to join us and contribute to the CDex example building process. If this is something of interest to you and you think that you can help contribute to this effort, the CDex community meets weekly on Wednesdays at 2 p.m. Eastern Time. Next slide, please. So moving on to member attribution. The member attribution list implementation guide provides trading partners the ability to establish, validate, and maintain a list of shared members. We recently balloted STU2 in January of this year, and most recent updates support reconciliation of patient lists to add and remove members and changes to the group resource to support other implementation guides such as gaps in care, risk adjustment, and payer data exchange. In addition, the guide now supports alignment with the CMS data at the point of care pilot program, giving providers access to Medicare claims data for their Medicare patients, and the CMS beneficiary claims data API, which serves ACOs participating in the Medicare Shared Savings Program and other eligible CMS alternative payment models. As part of this most recent update to the guide, we also generalized the attribution list profile support, which supports multiple use cases, which requires patient lists. In looking ahead, this profile will eventually be moved into the HREX implementation guide as a foundational component for use across all Da Vinci implementation guides. There's still opportunity to engage in ballot reconciliation from the most recent ballot cycle. Discussions take place every other week on Wednesdays at 3 p.m. Eastern Time, and we hope folks will commit to testing at upcoming Connect-a-thons, especially for the newly added functionality in STU2. Next slide, please. So again, a visual depiction of how the member attribution lists work. There are two examples in the member attribution list exchange scenario, which are described in the implementation guide. In this scenario, the data producer or the payer uses historical claims and other information about members to create the member attribution list for the data consumer or the provider. And once the provider receives that list, the provider reconciles the list internally and notifies the payer of any specific changes. Steps 2 and 3A will be repeated as many times as needed. And once that list is finalized, the payer and provider agree to exchange that list periodically. This is currently considered the most common workflow, where the payer informs the provider of the list and makes the list available to the provider at regular intervals. Next slide, please. Most recently, this slide depicts scenario 2, which was most recently added to the STU2 implementation guide. In this scenario, the provider creates the member attribution list in the payer system. And once the payer receives the list, the payer may reconcile that list internally and notifies the provider of any changes. The provider reconciles the list internally and uses the member add and or member remove APIs to add or remove members from the list. Again, steps 3 and 4 in this scenario may be repeated as many times as needed until the provider and the payer agree upon a final list. This same list can be used as a starting point for the bulk data access process to extract requested data for all shared members in a list and make it available in an ND-JSON format for easier exchange of large volumes of data. We are really excited about this new and enhanced functionality, and we need people to help us test these scenarios and provide feedback for ongoing improvements. And we can't wait to hear how Anna and Megan have implemented features of this guide to support operational efficiencies within their own organizations. Next slide, please. Lastly, each week there are numerous Da Vinci working sessions that are open to the public. Anyone can join the Da Vinci public calls and participate in the standards development process. This slide contains a summary of a majority of those calls, all of which are listed in the HL7 Conference Center, where you will be able to find webinar and dial-in information associated with each call. There are no meeting appointments or invitations that are sent out. You have to visit the conference call center and add them to your own calendar. And we also encourage you to join the Da Vinci listserv to receive announcements about cancellations and changes to those conference calls. So please feel free to reach out if you have any questions about how to engage in these activities. We would be more than happy to help you with that. I will now turn it over to Alex, who I think may open it up for some questions if time allows.
Yeah. Crystal, I thank you for that lob. I'm going to hold off on questions for a moment because I know we are responding to a few of those via the question submission box. I want to make sure we've got ample time for Megan and Anna to showcase their storyline about how to improve interoperability and patient safety through patient matching success. And then we'll take the questions at the end for all of the presenters today. So thank you, Megan, for coming on screen. I believe I'm going to advance to the next slide for you, and maybe one more.
Excellent, thank you. Yeah, maybe to stay there for a second. So, first of all, I know, I just want to say thank you to everybody that's joined us. I know for many of you, it's late in the day. It's approaching 5 o'clock for those of you on the East Coast. So we're going to make this as engaging as possible for you. Go ahead and stand up, stretch, do what you need to do. But please put your really, really tough questions into the chat so that Anna can answer those for you in a little bit.
There's already one in there.
But seriously, we do want this to be interactive. We want this to be a discussion. Both Anna and I are very excited to tell you our story, but please engage with us and ask us questions today or separately after this webinar as well. So by way of introduction, my name's Meghan Quint. I have expertise in organizational effectiveness. I have a PhD in organizational psychology, and I've worked with many of the companies in the Seattle area, including Boeing, Microsoft, Starbucks, lots of household names. For over a decade, I actually worked with Premera Blue Cross, leading innovation and strategic partnerships, where I developed a true personal and professional obsession with making healthcare work better. And from that, landed where I am now, which is as a founding executive at Opala in the role of Vice President of Solutions and Customer Success. Opala was founded in August of 2020, and we were initially focused on helping health plans, payer organizations meet the compliance requirements of the 21st Century Cures Act. But really we are focused on creating complete longitudinal patient records and provider directories that were organized as FHIR resources and available as APIs. And we believe that we are uniquely positioned to do that for payers and to be partnering with providers, because we come from healthcare and we understand the nuances of why this work is so hard and why organizations and collaborations like Vinci are really critical to make progress in this space. And the case study that we're going to tell you about today is truly a demonstration of that. We're in the business of creating win-win solutions for payers and providers administratively, but ultimately to benefit patients. And our mission is actually to collect, standardize, and consolidate healthcare data to build a complete picture of patient health. So with that, I am so privileged today to co-present with one of my partners in interoperability, Anna Taylor of MultiCare Connected Care. And Alex, if you could advance us to the next slide, I will let her introduce herself and MultiCare.
Thanks, Megan. And Megan is my spirit animal, so we share the same joy in life. And we are obsessed with figuring out how we make this healthcare thing better, because there is lots of opportunity to do so. And selfishly, it's for my next gen who will need healthcare and needs healthcare today. So for our communities that we serve, is very important to me. For those of you who don't know me, I come from an engineering background. I'm a human factors engineer. I have worked in healthcare my entire career since I was 15, and we were still using paper charts. So there you go. I used to archive charts in the summertime at a pediatric practice, so I know what those look like too. I am from MultiCare Connected Care. We are a group of providers and a population health engine. We have over 380,000 lives under risk. We're headquarters out of Tacoma, Washington, and we have about 5,200 providers that we serve within this network that has about 30 EHRs. So you can start doing some multiplication things, and when we're talking about moving data from point A to point B, it becomes essential to our business operations and our infrastructure that we can handle standardized means and ways of exchanging that data and information. So really important work that we believe in and that we will continue to do and invest in, and looking forward to sharing the rest of the story. So I'm going to hand it off to Megan to talk about the solution, the problem and the solution.
Yes, thank you. So maybe starting with the problem. In my intro, I talked about the nuances of healthcare complexity and why, so badly I wished all the geniuses in Silicon Valley could come and just apply all of their tech solutions to healthcare, and it would be so much better. But we all know it just doesn't work that way. Healthcare is complex, it's unique, and if you don't understand that, the tech solutions that work in retail or in other industries just aren't going to transfer perfectly to healthcare. So I wanted to start by sharing a slight tangent, but a backstory for how MultiCare and Opala came to even be prioritizing this IG for implementation. Initially, we actually set out to solve for extracting data from the EHR for a payer. And just as you would expect, payers only have data on their members that comes from claims or from bills, but EHRs have such richer information than what comes through on those bills. And right now there are lots of manual downstream expensive processes in place that I'd like to get upstream of and automate, things like supplemental data exchange, medical record retrieval. Would love to be rid of all of that. But when I was talking with Anna about how we could begin pulling clinical data using CDex or any of these really great solutions out of the EHR for a payer, we realized that, MultiCare didn't have a great way to feel confident about which patients to be sending clinical data for. So we're like, all right, let's solve that problem first. Let's figure out how to get you a reliable list of patients that then you feel comfortable sending clinical data for, and we don't have any risk of a HIPAA violation or anything along those lines. So I know that's a tangent, but I want to share it because the Da Vinci ATR API implementation guide is just that. It's a reliable, automated way to get lists of patients to providers. And there's so many use cases for that. But this use case in and of itself is a very worthy one. So we'll talk about how just implementing ATR API is valuable in and of itself. But I did want to share that broader context of what this truly unlocks in terms of value-based care for providers and for partnerships between providers and payers, for the benefit ultimately of patients. Okay, so if we could go to the next slide. This was like, great, let's tackle that first, so then we can start exchanging clinical data. And this is hard. It's a really good use case for a Da Vinci industry standard. And you heard a bit already from Crystal, but there's no good way for providers to estimate or guess about which of their patients are attributed to them under a value-based contract. Most health plans don't have PCP assignment. So the way value-based care works is payers use that patient's utilization patterns. They look at where that patient's going to the doctor most, and then they apply logic to say, okay, based on where that patient is going, they're a MultiCare patient or they're a patient of provider X. So because that's happening inside the analytic walls of a health plan, they then need to get that list over to those providers to say, okay, we're on a value-based contract, here's your patients. The challenge with that, though, is that just like there's variability in the logic for what qualifies as a PCP and how many visits and which logic trumps this, like if you go to an ER 10 times, does that trump a primary care visit? The logic's very complicated. But there's also variability just in the delivery and format of these files. And I'll let Anna talk about this more, but even just with a single payer, providers often have many value-based contracts. So not only are they getting one roster from each payer, they're getting lots of rosters from payers. And there's nothing even to say that a roster from a payer follows the same format and delivery method as a roster from that same payer. Often they don't. And that's crazy, but that's just how it works today. So, this is such an important thing to solve, to make it so much more efficient for providers to have a way to know which patients are attributed to them under a value-based contract and standardize that delivery and format across all their contracts and all of their payers. So if we go to the next slide, that's what we did with the Da Vinci ATR attribution API implementation. Essentially, we put in place an automated solution that follows this industry standard. It follows the Da Vinci implementation guide. What's really great about this is that MultiCare had done a proof of concept, but it was really a test of kind of a one-to-one connection. This implementation with Opala was the first scalable many-to-many type of an implementation that followed the draft IG, the draft implementation guide, to a T, which meant there were a lot of kinks to work out. Security included, that was a big one. And what was so great about this partnership is not only did we work that out so that MultiCare and Opala had it sorted in our implementation, but we actually worked it out in the Da Vinci work groups to update the implementation guide and capture these learnings and be solving it in a way that actually was a many-to-many solution, not just a Opala to MultiCare solution. So if we go to the next slide. Thank you. I'll let Anna get into all of the specifics about all the awesome outcomes of this. But what I'm really proud of is that this is an automated solution. It's a many-to-many solution, which means it's scalable for a provider like MultiCare across all of their payers, all of their value-based contracts. This solution that they've implemented now could work with anybody else that's able to do attribution API according to the Da Vinci IG. Going back to that initial use case I was trying to solve for of wanting to get clinical data from MultiCare for a subset of patients, that would require reliability, and we achieved that here. We're seeing less than 3% error rate in terms of matching between the patients on the attribution API roster from the payer and the patient's medical record number in Anna's EHR. So that's very exciting to see that low of error rate. And it means that this is now a reliable patient list that we can use as the basis for things like clinical data exchange. It's also something that we can use for just general value-based care partnership work, like outreach to patients, care gaps, suspected conditions, hospital alerts. It can really support this proactive care instead of just reactive care with a window of information that's in the EHR from care received at that provider group. So with that, I'll turn it back over to Anna.
Awesome, thanks, Megan. The solution, you can stay on that slide for a second, thanks, just for a minute. I just want to talk a little bit more deeper into that value. So now Opala, who services one of our payers, we have a data exchange with them that's using ATR. And what that enabled us to do was take our solution that we had put into place with another payer and prove that that works. So step one was proving that this is going to give us a return on investment, which it does. And you see that in that match rate, because when you're doing value work, when you are under risk as a provider, you don't have just the EHR that you have to communicate to. You might have a population health engine. You might have a financial data warehouse. You might have an actuary data warehouse. You might have a claims data mart, all those things that need to be able to identify patients and match members as we proliferate that list throughout the ecosystem. So super important that we're matching at this super high rate, because each one of those systems is a matching queue. And traditionally in the past in medicine, which I had to go do some deep web digging on this one, like, what do people do? What do companies do? They just create a duplicate. So now, that's the history of duplicates, is that if it doesn't match, I'm going to create a duplicate. It's safer that way. We can't manage it otherwise. It creates too much of a big of a matching queue. Well, now I'm able to not create duplicates and match at a 97% rate, and sometimes higher, sometimes 99, which is super important as we continue to take on more and more risk, that I'm not having to manage 9 matching queues or 10 matching queues and each having 1% in them. That's impossible as a provider. We don't have that kind of resource. So this value from implementing something standard that can pop through the ecosystem quite efficiently is huge to us in reducing that administrative burden. And it also means that it's governing a lot of our exposure of data. So we want to make sure the data we're sending to and from our payers and to our partners and to our third-party downstream vendors is the data that should be exposed, and we can more discreetly do that with this type of solution in place. So we're really excited about the value it's created. We now have 2 payers live on this. It's a one-to-many and actually a many-to-many. As Megan said, it's a many on her side. She can hook up more providers on her side, and I can hook up more payers on my side, and hopefully we'll all be doing the same handshake together as we work towards the future. But I am going to address one question in the chat that talked about the how are patients assigned, aligned, how do you make that happen? When we first started this use case, we focused on the scope heavily. Okay, do we put any logic into how that patient list is created? And the answer is no, it's just a patient list. All those complex 80-page, yes, 80-page for MSSP sometimes, algorithms that produce these patient attribution lists, we are leaving outside this scope. So determining the list is not a part of what ATR is. And if that's not the question you're answering, that you're asking, will you please clarify, Janice, so we can get that right for you? I want to make sure I answer that, but I think that's what you might be asking. Okay, so lots of value, and guess what? Implemented in weeks and not months. Implemented in weeks and not months. The security part is hard. Make sure everybody can do complex key exchange as the Da Vinci IG recommends. This is how security should go, how the handshakes should go. In our first implementation, we weren't as complex in that. In our second implementation that's going to scale, we were more complex in meeting the rigid requirements of those pieces. So this is something that you can do, but it looks hard, but you can make it happen. It's a lot easier than you think it is, and it doesn't take very long. All right, next slide. So what are we getting out of this ATR? What's the value for a provider? And here's what we're seeing, and I've shared this many times before, but we decrease those patient matching rates by 60% or more when we're trying to match everyone together. This is reducing that 10 minutes to chart, sometimes more, depending on how complex the mismatch is. And that produces almost a whole FTE per week, per year, a day FTE per week, per year for one payer. So I'm just going to go ahead and multiply that by the 18 attribution lists that I receive, and we get a huge reduction in administrative burden when we're implementing ATR. So we're going to work towards STU2, the second version, is more focused on having a digital conversation of reconciliation, which is also really important when you're considering Medicare Advantage contracts and those that have a higher amount of risk involved, where you really want to make sure your members are your members. There are errors in that too. There's errors everywhere. And I want to make sure that we're able to have that conversation back and forth. So that's on our roadmap, is to advance to the next version of that, so that we are enabled to have those two-way conversations with our payers in the market. All right, next slide, please. So the multiplier, the best part of this entire thing, and in everything we're doing. This is everything Vanessa talked about, Alex, Jocelyn, Crystal, they are all talking about a standard, which means I can use it as a many-to-many solution to exchange data and information with my payers without having to log into a portal, pull the file down, save it to my desktop, pray that laptop never gets stolen. I take mine everywhere with me. It just stays on me, and I know it's with me. And then you have to load it into your systems. Then you have to aggregate it yourself and squish it all together, and nothing talks to nothing's similar in the payload. And it just takes too much administrative burden to make that happen. It's more like gluing things together than it is actually analyzing who your membership is. And with this solution in place, I can multiply this by every single provider, every single downstream system, just as I shared previously, all those numbers, 8 downstream systems, 18 attribution lists. And And these are things I could share with providers in my network, 30 EHRs. I could share that list with my providers in my network as well and enable their EHRs to identify their risk-based members. This is all things that are possible with this type of solution in place. It's worth the infrastructure investment for that scalable solution. Those numbers you saw earlier was from our proof of concept, which is why we got supported to do the larger infrastructure build to scale the solutions. So we're really open. We want to share this. We want people to ask us questions about what makes us, what can we share and how to do it. We'll tell you. You can see under the hood. We want everyone to try and adopt this type of technology because it's for the betterment of healthcare in our communities. And we shouldn't be competing on interoperability at all. We should be competing on care and what we can bring to people's lives. So this is really important work to me, and I'm so thankful to have Meghan here today to talk with about this solution. And I think I'm going to pass it back to Alex to be our question guru here in the chat.
Yes, thank you so very much. Fantastic content. I think we really have a deeper appreciation of standards bring values and scalability. And we do have a couple questions that have been coming in, and some of them have gotten answered along the way. Thank you, Anna, and others who've been providing the response back and sharing that more broadly with the attendees. So there was a question kind of followed up on your response to Janice's earlier question while you were doing your commentary, Anna, and she really wanted to clarify, are you looking to incorporate that specific treatment relationship moving forward within the member attribution lists?
Yeah, so, and then she clarified down here, yes. I was wondering if there are plans to expand support given the treatment relationship requirements in interop and PA and all those things. So this technology is the foundation for which you could say, all right, I'm only sending these patients PA requirements to this payer because I have the list to do so. So it's a layer of security that we can now put an envelope around all the use cases we have in place with Da Vinci that enables us to create lists of people who opt out. We just will have more intelligence around how we enable that to happen. So I think I'm answering your question, but I think there's something deeper there, and I would love to have coffee and go into in-depth conversation about it. And people know that I will do that. So you just call me and we will have a conversation.
Well, a similar question kind of coming in on ATR, and I'm thinking maybe Meghan, you want to answer this about hearing more about the patient matching algorithm and what elements you're matching on, and are you using an industry standard such as what they're leveraging for FAST, the Fire at Scale Task Force has been working on, recognizing that this is a pretty hot topic in the industry for the patient matching, and any commentary you'd like to offer around the algorithm aspects and what elements you're using in it.
Yeah, it might actually be more of a question for Anna, because the matching that she's talking about is, essentially matching it, matching the sort of Opala identifier to her systems and all those various identifiers that her systems create. So, Anna, do you want to talk about that?
Yeah, sure. So the answer to that question is our patient matching system utilizes the FHIR architecture. So when the lists come in, it gets stored in a FHIR database, essentially. Our FHIR services, it's all based on FHIR, and then we have a service that speaks in the FHIR architecture and does a one patient record. So there's a tool that we have that masters all the data around that patient or member to enable us to produce one list on the outside. So we have about 18 lists coming in to we call it our master member database services. And those services are then handed off to, and because I know the person who's asking this question, to a roster management engine. If any of you have Epic as your EHR, that is the tool for which Epic ingests a membership list. It's called a roster management engine. So we have a standard file that is produced for that roster management engine that is based on ATR. So it's all the ATR spec. Basically, that's the payload. It goes into there. The one thing we add is a unique ID that comes out of that mastering service, that tool. And that unique ID enables us to permanent match records so that they don't have to be rematched every month. So we have a unique ID that lives within MultiCare, and that unique ID enables us to do permanent matches within our ecosystems. And we actually didn't have that to begin with, and that became a problem because we were having so many, some of the contracts, you'd be surprised, in some of our files, we have like a 50% fill rate on a member ID. And so we had to create one ourselves to be able to get that matched. So hopefully, I have not been looking at what FAST is doing. I probably should. That is my next step. I've been super focused on prior auth, and now my brain is moving on to DEQM and CDex, but I need to go back to patient matching because that is just foundation to what we do.
Sounds like you might benefit from going to the working group meeting plus, because there'll be some presentations from FAST on their effort.
True.
All right, so let me see about some other questions that have come in. I think we fully answered Samir's question to you, hopefully. And she says, yes, that was very helpful. So she thanks you and looks forward to further chatting with you. We're also already in motion to put you and Janice together, Anna. And so Jocelyn, Keegan, are you out there in the sphere? Are you still with us?
Yes, I am.
All right, so we've had a few questions that have come in. I think we've been addressing related to the proposed rulemaking and sort of the translation aspects, and wanted to give you an opportunity to sort of chime into the community and build on the comments that you've been sending back to the submission requests related to our stance on the attachments NPRM. You want to start there?
Yeah, I like that you're pitching that one to me as the person that wrote the letter. But sure, I think that sort of holistically, I think that, just if there's any questions or clarifications that are needed out in the audience, I think that, we as a community have been heavily invested in moving towards FHIR and the FHIR APIs. We also, I think, are following, the lead that's coming out across a number of ONC and CMS regulations around sort of shifting the industry to APIs. And so not surprisingly, when we convene our team of members to discuss sort of where we want to weigh in on topics, I think folks felt really heavily that if we were talking about support of prior authorization and other general clinical data exchange, that people really wanted to see us move forward with FHIR as an industry. I do think I'll probably share a little color commentary. I do think there's a lot of discussion in those attachment-specific conversations around protecting and preserving and understanding that there's an industry investment in the existing 275 standards and the X12 infrastructure, and that we wouldn't want to derail sort of progress that folks have made on that front. And so, we sort of debated sort of, I think, pretty in a pretty fair way amongst the group whether or not we wanted to, sort of give any advice on that standpoint. And we decided, I think, as a community to really speak on behalf of DaVinci and FHIR and sort of where DaVinci wants to be headed. And I'm sure folks will see in the coming weeks commentary maybe that might differ, that's a little bit more split from some of our membership as they publish their own commentary out to CMS. I'm going to say out loud, I think Alex said at the beginning of the call, if you're not paying attention, the feds did push by a week. By a month. And so I would guess we're probably going to see a little bit of a pause on attachments commentary getting submitted to the Federal Register, but we'll continue to monitor and watch that just as part of our industry engagement. And then on the flip side of that, I don't think there were any surprises really in the Interop 3 rule. I think, as usual, we're providing guidance where our guides are being mentioned, clarifications where we think it's necessary, where maybe we think the feds haven't gotten it totally right from an NPM perspective, nothing personal. My colleagues that work in CMS, which is a lot of brains, and I think that, these documents are draft and comment periods exist for a reason. And then I think that we really see wholehearted support. I think that what will be sort of the proof in the pudding as we move towards a final rule is, really people starting and picking up guides if they haven't already and getting started, and how are we getting from today, right, in 2023 to a final implementation date in 2026. And lots of conversation in the community, I think, around understanding that there's a difference between saying we need to have API live and when is it going to be to a point where we can understand what we should be certifying on and how we certify those technologies, which I think is tied up in a lot of activity in the industry around how and where we're really going to understand the layers of APIs that are going to be involved to bring some of these full transactions and fully automated transactions live in production, multi-party transactions. Is that getting at the heart of what you were looking for, Alex?
I think it is. I think it also helps with that we are in a modern world of APIs and RESTful exchanges, and we're expecting to be able to get stuff on our phone and access our information just as easily as we're able to order socks, but to be ensure that we have the right, from Amazon, but be sure we have the right security and privacy provisions associated with our data exchange. And so I think it's really interesting to see the juxtaposition between the Interop 3 rule and the attachments rule, and that we understand, to your point, that there's a large install base and that we really want to move everybody forward. But this is really focused around the patients and addressing burnout, and as we addressed in our letter, this concept of the quadruple aim that we're all striving to achieve. So I'd like to ask Anna a particular question, so maybe she'll come back on screen with us. And I'll wait for her to appear. I gave her a heads up. Anna, are you with us?
Yep, I'm coming.
Awesome. Okay, so let's talk about what does interoperability mean. And Megan, you're more than welcome to join us as well if you'd like to have some commentary on this. But what does interoperability mean for patients? Because that's what all of this is about. As we are all humans, we're all going to be patients at one point or another. We've got this provider-payer ecosystem swirling around us as supported by standards and policy and vendors. But what does it really mean for patients?
Well, this is probably a little charged, but I feel like it enables patients to own their data, to bring data where they want to get care, where they can get care. It enables them to empower their providers with more information than they have today. Medicine is a lot of process of elimination. So the more data and information we have that's relevant to the situation is going to help enable us make a better diagnosis in the end. It's just something that we don't always get to an answer right away. And people are like, why do I have to wait 2 years to get a diagnosis? You hear stories of that. But as we get more and more sophisticated in being interoperable, and we're no longer talking about this, we're actually talking about, getting a diagnosis on day 10 or something to that effect, or being able to take my health record to wherever I am on vacation and have all that data and information there for that emergency department or urgent care. I have small humans. We like to frequent those. So to me, it's empowering them. It's empowering them to be a part of the conversation, to own their health, because ultimately we make the choices for our body, hopefully most of the time. Won't get into that on this, but it's super important for me to do anything and everything I can to empower patients to be able to live their best, healthiest life. And that just lifts the entire communities. If we can get the individual, we can lift the community and really leave this planet a better place than we found it.
Well said. Megan, do you want to add to that?
Well, it's going to be really hard to, top that. I think that the only addition that I would have, there's two things. One, it's like, let's take the burden off the patient to have to play doctor and know what they even need to tell their doctor, right? Because right now, the information the doctor has is mostly based on patient self-report, and they're often, guessing when they're asking the patient questions, and then the patient gives their best answer, but they're not a clinician. When they're giving prescription lists, they're not they may not know the drug name and the dose and the prescriber. They're like, and they're also probably in pain or afraid or otherwise, not their most coherent self. So that's how we're, relying on information for treatment decisions and for informed provider-patient decision-making. That's not very good. We can do better than that. And then the second is just the provider burnout. Let's get providers the information that they need so that they can be with the patient and treat the patient and not be burdened by administrative stuff, by gathering records, by sorting through too much information. Let's contextualize the information so that they have the right information for what they're trying to do right now. That's what this is about for me, is really empowering that provider to be able to do patient care, and then ensuring that the patient can truly just be the patient. They don't also have to be, burdened with bringing their complete medical record and trying to translate that for a clinician when, most patients are not clinicians.
Very well said. There is a very multifaceted and complex set of issues that we're trying to tackle, and it's really good that we can make sure that we're getting the right patient, the right data at the right time to really help automate those workflows and harness the power of technology. And that's what the Fast Healthcare Interoperability Resource Standard really does for us, and why the Da Vinci community has leaned into it heavily for our last 5 years to advance value-based care exchanges, because it is all about the patient and addressing the burnout and pain and overhead and duplicativeness of our healthcare system. So with that, I'm going to wish you all a good rest of your day. Thank you for joining us. We'll see you back on April 26th for the next Community Roundtable. We will be posting our session details in the next couple of weeks, and stay well.
Thank you. Thank you, ladies.
Bye.
Hi, thank you.